cervix, you can see the fungal hyphae and the buds. This is again Candida, but this time this is sputum. You can see cells which are flat epithelial cells, and these are from the buccal cavity. You can see some of the cells on the top of the slides which are a bit rounded. These are the cells from the respiratory tract. So this is an infection from the upper respiratory tract and the mouth. In case of Candida infection, we see white patches in the mouth and in vagina. If there is esophageal candidiasis, again on endoscopy you can see white patches. That is why on the appearance clinically, and same way its appearance on the Seborrheic agar, the fungus is named as Candida albicans. This is Seborrheic agar showing fungal colonies. This is tongue showing oral candidiasis. This is called oral thrush. Same way, esophageal thrush, or we call it vaginal thrush if it is a genital infection. You are going to see candidiasis mostly in immunosuppressed patients, in patients having cancer, in patients having immunotherapy, in patients undergoing chemotherapy and radiotherapy, and also in patients having long standing chronic diseases. And most important is diabetes mellitus, and in case of diabetes, uncontrolled diabetes mellitus in old age females, you can see vaginal thrush. This is esophageal or gastrointestinal candidiasis. You are not going to see candidiasis um, in the other part of the GIT other than the esophagus. Um, if you see Candida hyphae or buds in the stomach or in the intestine, they are just the contamination from the esophagus. Only the esophagus is going to show you patches like this. One of the important clinical points in this is that if you are going to scrape this patch, it is going to detach from the surface. So this is a superficial fungal infection, even in the mouth, in the vagina, and in the esophagus. If you are going to remove this patch, it is going to detach from the surface. This is one of the important differential diagnoses in detecting that whether it is a fungal infection or it is an exudative patch. If there is an ulcer underneath the patch, and if you detach this patch from the surface is going to bleed. But in case of candidiasis, if you are going to remove this patch, it is going to just detach from the surface. Because it is a superficial fungus, there is no formation of ulcer. This fungus is not even penetrating the epithelium, so there is only going to be redness. That means that there is inflammation, but there is not going to be any bleeding. So clinically, if you want to differentiate between the Candida infection or an exudative patch, you can detach the patch and you can see. Another fungus, a budding fungus, is Cryptococcus neoformans. Cryptococcus neoformans is a budding fungus. It is not a dimorphic fungus. It is not seen in a hyphal form. Uh, Two budding fungus are Candida and Cryptococcus. These are important for you. Candida, you are going to see in immunocompromised patients mostly, and same way, Cryptococcus neoformans, you are going to see again in immunocompromised patients. It can produce skin infections, it can produce respiratory tract infection, but most importantly, it produces cryptococcal meningitis. So, a fungal meningitis is caused by Cryptococcus neoformans. So if you get an MCQ or you are asked that name a fungus which can cause meningitis, that is Cryptococcus neoformans. Um, Cryptococcus neoformans meningitis. If a fungal meningitis is diagnosed, you should be cautious that the patient is immunocompromised. Cryptococcus neoformans meningitis can never occur in a immunocompetent person. This is a budding fungus, Cryptococcus neoformans. A very interesting test about Cryptococcus neoformans is called an India ink preparation or India ink test. India ink preparation is that this is one of the fungus which has a capsule around uh, the bud, and that is a jelly like capsule. If you have CSF from the patient of meningitis having a cryptococcus meningitis, first you have to take a drop of CSF, put it on a slide, put a cover slip, and see if you can see some buds, and you want to confirm that whether it is cryptococcus or not. You just have to put a drop of black ink, that is called India ink. uh, Interesting thing about this India ink is that it is not a dye or a stain, it is just a drawing ink. And another interesting fact is that there is nothing to do with India. This ink is made in China, and this is just a name given to this ink because of its uh, use in the art. So it is an India ink preparation. If you put a drop of ink, that is black ink, underneath the cover slip, the entire CSF is going to turn black, and the ink cannot penetrate the capsule. There is going to be a halo around the budding fungus or the bud. So that is a confirmatory test that this is a Cryptococcus neoformans, and this is an easy confirmatory test just on a slide. So see this, uh, on the left hand side, you can see a stained slide, hemadoxylin eosine stain. You can see a well developed capsule. And on the other side, you can see an India ink preparation. And you can see the bud, and you can see the white area, which is the capsule. See this. This is another India ink preparation. So, there are two types of budding fungi, two important budding fungi which you are going to deal with when you are going to go to the clinics. One is Candida, another is Cryptococcus neoformans. Both cause infection in immunosuppressed patients. This is again Cryptococcus neoformans, but this is a silver staining. Silver staining, I told you in the last lecture that this is a special stain for fungus. Silver stain is also called GMS, that is Gamori methanamine silver stain. The fungus is going to turn black. Any type of fungus is going to turn black, and the background is going to stay green. So this is one of the confirmatory tests that the fungus is present. Whether it is a hyphal fungus or a budding fungus or a dimorphic, any type of fungus is going to turn black with silver stain. This is a skin infection, a big ulcer caused by Cryptococcus neoformans. As we dealt last time, that there are three types of fungi: budding fungus, a hyphal fungus, or a dimorphic fungus. So you have yeasts, you have molds, and you have a dimorphic fungus. This is just to revise the last a thing in the last lecture, that you have conidia. Those are spores on the tip of the hyphae, and you have two types of fungi having such type of conidia. One is penicillium, and other is Aspergillus. Penicillium is a useful fungus, while Aspergillus is a harmful fungus. So, to differentiate between these two, this is a Penicillium, this is an Aspergillus. So Aspergillus, the conidia, they are in the form of a ball or a Japanese or a Chinese fan. But in case of Penicillium, they are just attached perpendicular. Many conidia, they are attached perpendicular to the tip. So this is Penicillium. This is Aspergillus. So penicillium is a useful fungus. We get penicillin from this fungus. It is a hyphal fungus with conidia. So this is penicillium. This is electron microscopic picture. This is a culture of penicillium on the Sabouraud's agar. So Sabouraud's dextrose agar is one agar which is used for any type of fungi, and you can get different characters or patterns of the colonies. So differentiating, on the left hand side you have penicillium, and on the right hand side you have Aspergillus. So we are dealing with Aspergillus now. Aspergillus, this is a fungal infection in the lungs. This is a respiratory tract infection, and this is a systemic infection. As we did in the last lectures, that there are three types of mycosis: superficial, subcutaneous, and systemic. So superficial, the example till now, the example is Candida and Cryptococcus and this Aspergillus. These are both systemic. Cryptococcus can also cause a superficial and subcutaneous fungal infection on the skin also. But Aspergillus is a systemic fungus. The spores are inhaled through the nose, and it is going to form a granuloma in the lung. So it is a respiratory tract infection, and uh, the lungs, they are involved. So aspergilloma is just a name given to the lesion seen in the lung field. But as I told you in the initial lectures in the start of the third year, that on x-ray you cannot diagnose granuloma. Granuloma is a microscopic diagnosis, so you are not going to diagnose granuloma on X-ray. It is a biopsy or a microscopic diagnosis. Aspergilloma is just a name given to the lesion formed by Aspergillus in the lung. So you are going to take a biopsy through a bronchoscope, and you can see Aspergillus in that biopsy. So it is a systemic infection, and you're going to give systemic IV antibiotics, that is antifungal, and one of the important is amphotericin B. So amphotericin B is given against any systemic fungi. This is one of the fungus which is angio-invasive. Angio-invasive means that it can invade the blood vessels and can cause septicemia. So this is one of the fungi which is angio-invasive. I'm going to tell you another one later. This is mucor. Mucor is one fungus which is not budding, which is not hyphal fungus. It is having pseudo hyphae. In the last lecture, we did what is pseudo hyphae. We discussed that there are patterns of hyphae which are you cannot call them buds, or you cannot call them hyphae because they are not thread-like structures. They are in between, so they are called pseudo hyphae. They are non-septate pseudo hyphae, and if you can see in the slide, you have dust-laden alveolar macrophages, and you have some non-septate hyphae. Mucor is the second angio-invasive fungus. It is a deadly fungal infection. This fungal infection is seen in immunocompromised patient. This is one of the typical pictures of a mucormycosis. It is a respiratory tract infection. It causes infection in the nasal cavity. It causes infection in the paranasal sinuses. And the deadly thing is that if it is not treated with IV amphotericin B injections, it is going to penetrate the cribriform plate and can cause invasion of the brain. So if brain is involved, it causes fungal encephalitis, and it becomes deadly for the patient. So two fungi which are angioinvasive are aspergillus and mucor. So mucor is one fungus which is having pseudohyphae. There are two budding fungi we talked about, Candida and uh, Cryptococcus. Candida is also a diamorphic fungus. So this is a diabetic patient, and this is one of the typical examples, clinical picture of mucormycosis. And just to share with you people that when I did my house job, this was the first patient on my bed on the first day of my house job. Unfortunately, the patient died within 2 or 3 days because the children of that patient, they denied IV therapy by amphotericin B. So he was not given. He was a diabetic patient having an uncontrolled diabetes, and the IV amphotericin B was not given. So it caused the encephalitis. So, why saying that this is one of the typical clinical pictures? Because the fungus is going to infect the nasal cavity. The fungus is going to cause infection and inflammation and swelling of the cheeks. That is because the fungus is in the paranasal sinuses, and then the infection. This is not the infection in the eye. Actually, this is that there is infection in the paranasal sinuses, so that the eye is popping out. The best test is that you're going to take swab or the secretions from or the discharge from the nose, and you are just going to see it under the slide. You can see pseudo hyphae, and if you stain it with silver staining, you are going to confirm the diagnosis. This is the involvement of the brain by mucor, and you can see the pseudohyphae. These are not thread-like structures, and there are no buds even. This is another fungus other than aspergillus, which can form granulomas. So granulomas can be formed in the respiratory tract and can be seen, and rarely can be seen in the brain. See this, these are pseudo hyphae. Just want to emphasize on this. This can be something else. So if you have a good history along with the specimen, you are never going to miss that. So history is very important. Immunosuppression of the patient is very important. And one of the best common example clinically is uncontrolled diabetes, long-standing uncontrolled diabetes. This is a very nice picture of silver staining, and this is mucor, and you can see mucor fungus in the vessel. So two angio-invasive fungi, aspergillus and mucor. Superficial fungus cause skin infection, and this is the most common fungal infection you are going to see in the dermatology ward. Collectively, they are called dermatophytes and dermatophytoses. So this is a list of dermatophytes. These are called tinea, and tinea can cause infection anywhere on the body from head to toe, but they are named according to the area. And one tinea cannot cause infection on the other side of the body, so they are named accordingly. But the group remains the same, and the treatment remains the same. If there is infection on the scalp, you can call it tinea capitis. If there is infection On the feet, you can call it tinea pedis, but the treatment of both remains the same. It is a superficial fungus. Superficial means that it is just residing on the epidermis. It is not even penetrating the epidermis. So you have to give topical antifungal ointments for the treatment. This is uh, the fungal infection, and there is a word written ringworm. Ringworm is just a name given to the lesion of this fungal infection on the skin. I'm going to show you in the next slide. So ringworm doesn't mean that it is a parasitic infection. Ringworm doesn't mean that there is a worm. It is a fungal infection. Ringworm is because it is going to form a ring like lesion on the skin, mostly on the trunk and the abdomen and the back of the body. This is the dermatophyte. You can see it is a hyphal fungus with macroconadia, conadia present on the tip. So these are macroconadia. This is Saborad's agar, and this is the culture of dermatophytes. Tinea pedis, which is also called athlete's foot, and Tinea corporus, which is fungus or the tinea causing infection on the thorax and the abdomen and the back. This is Tinea pedis. This is Tinea corporus. See this, this is a rounded lesion, and this is also called a target lesion, like the target of the dart or the arrow. So this lesion is because it is called a ringworm. This is because of this lesion on the trunk that we call it a ringworm infection. And to highlight here that not all dermatophytes cause ringworm infection. We all we are only naming the tinea causing infection on the trunk as ringworm. This is just a nickname given to the fungal infection. So this is the tinea causing infection on the face. This is nail infection. This is tinea capitis, fungal infection on the scalp. This looks very horrible, but this is actually a superficial fungal infection. Nothing is penetrating into the epidermis. This is a superficial fungal infection. You have to treat it with ointments tropically. So topical antibiotics, you might have classified those in pharmacology. One of them is ketoconazole, and preparations related to that group. So one of the superficial fungus, most common example is dermatophytes, and you are going to see these type of infection when you are going to go to the wards. Uh, Three of the systemic fungi. Systemic fungi mostly cause infection in the lungs because the spores they are inhaled through the respiratory tract. Two of the systemic fungi we did previously, they were Cryptococcus and Aspergillus and Mucor also. Uh, more Three of the more important systemic fungi, one of them is blastomyces. Blastomyces is a budding fungus. You can see this is a bud. There are no hyphae. This is a respiratory tract infection. The spores they are inhaled and it causes a lung infection. It can cause infection in the nose or the nasal cavity also rarely. This is blastomyces. An interesting thing about the blastomyces and the other two we are going to deal after this blastomyces, that these three fungi, blastomyces, histoplasma, and coccidioidomycosis, these are not present in our part of the world. They are seen in certain states of USA. So if you have a patient with fungal infection with any of these three fungi, you have to take a travel history. So this is a budding fungus. There are broad based budding seen, and this is a hematoxylin eosine preparation, and you have to take sputum, or you have to take a lung washing or a lung lavage through a bronchoscope as a specimen. And you have to you can see it on the slide, you can stain it with special stains like silver staining, and you can just see the fungus. You don't have to go for cultures even. Histoplasma or histoplasmosis, this is a hyphal fungus with buds or spores in groups. So these are actually spores, and they are in the form of a flower perpendicular to the hyphae. See this? This is a culture of histoplasma on Sabouraud's agar. Histoplasma again is a respiratory tract infection. It causes infection in the lungs, and it is that you are going to inhale uh, spores from the environment, and you are going to have a infection in the lung. Granulomatous fungal infections. One is aspergillus, another is mucor, another is blastomyces, yet another is histoplasma. So, if you recall that in the classification of granulomas and in the etiological classification, we did infectious granulomas, and in those infectious granulomas, there was a heading of fungal granulomas. So, this is where we can fit those. So, systemic fungi, they are going to cause chronic granulomatous inflammation. So you can see granulomas in cases of aspergillus. You can see granulomas in cases of mucor and blastomyces, histoplasma. So birds and birds' feces are going to contain the spores. Again, that histoplasma is not seen in our part of the world. It is mostly present in certain states of USA. So histoplasma, spores, and spores are inhaled. They are going to go into the lung. They are going to proliferate. They are going to form hyphae and then a granuloma. See this? This is one of a good diagnostic feature of histoplasma, that histoplasma spores, they can be seen in a macrophage. So if you see sputum, and if you see a lot of macrophage in the sputum, or the lavage or washings from the lung, uh, if you look into that macrophage, you can see a number of spores, and that is one diagnostic point, that this fungus inside the macrophage is histoplasma, because the spores of the histoplasma, they are very small, and they can be engulfed, many of the spores can be engulfed by a single macrophage. So this is a spores in the macrophage, or a macrophage containing spores, is one of the diagnostic features in case of histoplasma. Again, this is silver staining, and in case of silver staining, the background is green, and the fungus is going to highlight as black. Lastly, coccidioidomycosis. Co- Coccidioidomyces is the name of the fungus. The full name is Coccidioidomyces imitans, and coccidioidomycosis is the fungal infection. This is endemic in South America. The first case was also discovered in South America from Argentina. See this. So this was the first case of coccidioidomycosis. This is a fungal infection. Again, it is a respiratory tract infection causing infection in the lung, but apart from the respiratory tract, it can cause infection on the skin, and you can see a very ugly looking infection on the skin. Uh, on the right hand side, you can see the head of that first case of coccidioidomycosis, and this head is present in one of the museums of a medical school in Argentina. So coccidioidomycosis is one of the systemic fungi which not only cause infection in the respiratory tract but also cause infection on the skin. And on the skin, it causes a subcutaneous infection. So that means that it can penetrate the epidermis and it is going to cause infection in the dermis. So it can produce ulcer-like lesions. So on the right hand side, you can see uh, covering containing a lot and lot of spores. So the characteristic features of this fungus is uh, covering with a lot of spores inside. When the cover or the membrane is ruptured, the spores they can come out and they can form individual fungi again and can produce a widespread infection. So it can cause infection in the lung primarily. It can cause infection in the liver, in the heart, in the brain. So again, this is the third angio-invasive fungus, but mostly the infection is seen in the lung, and the patient is diagnosed with infection in the lung or the skin, but rarely as a complication one can see, or the patient can present with brain, heart, or liver infection, but this is only present in certain case reports in the world. So this is a coccidioidomycosis or coccidioidomyces imitans, that is a fungal spore, a lot of fungal spores present in a membrane. So it can form budding fungi whenever the spores are out of the membrane, and they can cause a disseminated infection. See this, this is a tissue slide stained with hematoxylin eosine. So you can see the fungus again. So this is hematoxylin eosine. And if you stain this slide with PAS, that is periodic acid shift stain, this same fungus is going to stain dark pink in the slide. And if you stain it with silver stain, it is going to stain black. This is a granuloma. So you have a fungus in a fungal spore in the center, and you have epithelioid cells. So this is again one of the systemic fungi causing a chronic granulomatous infection. See this, this is a silver stain. So you have fungus. This is the membrane and a number of spores coming out of that ruptured membrane. So this is again a silver stain. This is paracoccidioidomycosis. This is a rare fungal infection, again present in the Latin Americas. So just see the difference between coccidioidomycosis. It is a membranous fungus, membrane without a hyphae, and a lot of spores present in that membrane, the budding spores. And in this case, a paracoccidioidomycosis, it is again a budding fungus, but it is having number of spores from a single, sorry, number of buds from a single spores. so it form a flower like pattern. So it is a rare fungus. It is belonging to the same group as coccidioidomycosis, so it is called para coccidioidomycosis. It mostly causes skin infections. So this is skin infection by paracoccidioidomycosis. So this was all about our important facts about certain important fungi. And just to summarize that, what we did today is that you have to know Candida infections. That is the most common. Candida is a superficial fungus. Thrush is the infection you call clinically when you see white patches in the mouth or in the vagina or in the esophagus. The other is Cryptococcus neoformans. Cryptococcus and Candida both are budding fungi. Candida is also a dimorphic fungi. Both cause infection in the immunosuppressed patients. Mucormycosis and Aspergillus are two angio-invasive fungi. Mucor causes infection in the immunosuppressed patients. It can not cause infection in the immunocompetent patients. Then systemic fungi are Aspergillus, blastomyces, histoplasma, coccidioidomycosis. So all of them are going to cause chronic granulomatous infection, and most of the infections, rather, all of these infections are primarily respiratory tract infection or lung infections. So this was a brief talk about the fungus. From next time, we are going to deal with um some topics related to immunology. And I'm not going to go into the details of the basic immunology because you have already done that in your biochemistry and physiology in detail. So I'm going to start with the HIV, that is immunosuppression disease. And then we are going to go to certain immunological diseases, hypersensitivity reactions,